My name is Dr. Zahid. I'm one of the doctors in the hospital.
Hello?
Are you Miss Monica, daughter of David Simpson, 78 years of age?
Yeah, I am.
Okay, Monica, I was told that you wanted to talk to me about your father's condition. So may I know what you're expecting and what we want to talk about?
I don't know. I didn't ask actually. My dad wants to have a word with you because I think you people told him something and he tried to explain me, but I couldn't understand what he's telling. So I just want to know about from you.
Okay, well, Miss Monica, I'm here to explain everything about his condition so far and the further plan for him. But
Hmm.
before that, I want to know that how much did you understand so that I can further clarify?
Right. Sorry to interrupt because nobody put the scenario. I'll tell the scenario. 78-year-old David Simpson came to hospital with shortness of breath and cough 1 week ago. He was treated with IV antibiotics for chest infection. He has COPD with frequent admissions to hospital. He was given non-invasive ventilation, which he didn't tolerate. Respiratory team has seen him and decision was to refer him to palliative care. He was for DNA CPR. David agreed and he wanted the medical team to discuss with his daughter. Speak with his daughter Monica and answer her concerns. You are the junior doctor in medical assessment unit. Yes, carry on.
Okay, so Miss Monica, I'm here to clarify to you further about Mr. Simpson's condition and the further plan of management. But
Mhm.
first, I want to know how much did you get so that I can add on to that.
All right, I know he has got COPD, like a chest problem. I think he's having for years and years and years actually. And it just like it gets an infection and then goes to hospital, treat the infection, comes back, and then he has a rescue pack at home as well. So it's a routine actually. See, it's a people see it as a disease, a problem, but for him, it's a routine actually. It's just like brushing your teeth and having a cup of coffee. He has to live with it, and he is living with it.
Okay, so I believe that because it has been present for so long, so it has become a routine.
Yeah, yeah.
But I want to clarify about COPD. How much do you know what kind of a disease it is? How do you get it? What problems it causes?
So it affects the lung, I know, and then a problem with the breathing. See, as long as you go to the hospital in the right time, you can, like for example, infection, you can treat it and then get better. See, it's like a
So,
diabetes. Diabetes, yeah, diabetes is there. So people are not worrying at the moment about diabetes. They just follow the diet regularly and follow the medications and so on. So, and then they can live a normal life like that. COPD, no need to worry about it. Yes, it is a disease, it is illness. He is not healthy, but still, he can carry on.
okay. So you're right in terms that like diabetes, COPD is also a lifelong condition.
Yeah.
But there are certain differences that I want to clarify.
Mm-hmm.
It stands for chronic obstructive pulmonary disease, by which I
Mm-hmm.
mean that there are certain factors which can cause some changes in the lung. It causes soreness in the lung tissue, and this
Okay.
can damage the walls of the breathing pipes and the smaller channels inside the lung.
Mm-hmm.
And when this goes on for a long time chronically, it can cause a lot of damage, and it can be so much so that it can severely impair the ability of the lungs to supply oxygen to the different organs of the body. And um, maybe in the longer run the person can even become dependent on oxygen cylinders to help them ventilate their
Yeah,
lungs.
yeah, he has oxygen. At home, he takes a 2 liters. Sometimes it goes up to three. So that's helping me getting definite benefit from oxygen. Yeah, yeah, you're right. Yeah.
So well, Can you tell me, was Mr. Simpson smoking?
Yeah,
Do
he
you have
used
any
to.
idea like how many cigarettes and for how long?
Yeah, he used to. Maybe 30 cigarettes per day. Yeah.
Is he still smoking?
No, he can't because he's got oxygen at home. It will
Right,
burst.
right. So one of the major factors which is responsible for this damage to the lung is the long-term and smoking in increased amounts.
Mm-hmm.
This can cause some permanent damage and scarring to the lungs.
Okay.
And how was he at home? Was he able to perform his daily activities? Was he able to do the chores around at home, take care of himself?
It's a bit tricky because, see, within the house is okay, but I don't think he can go out and then he need a like a wheelchair and Zimmer frame with the wheels on it over there. So I'm there. I'm just like 2 streets away, so I come there every day and help him.
Okay, so well, considering that he was not really active, he could not go out of the house, and he needed your help most of the time. And considering that he also needed oxygen, it shows that there was a lot of extensive damage to the lungs because of this disease. Because it was present for many years. It caused such extensive damage that it prevented him from doing his daily work, and he needed supplementary oxygen supply as well to help him to oxygenate his blood.
Mm-hmm.
And along with that, these
But it's
frequent
not
chest
something
infections.
happened new. It's happened nearly like he's like that for 2 years now.
Yes, okay. So also that you know that frequent chest infections, when there are repeated bug infections, these can worsen the situation for someone. Like you said me, he's been in and out of the hospital multiple times, and he's been given treatments multiple of times. That can worsen the damage to the lungs, and over the longer run, it can cause some irreversible scarring and damage to the lung tissue,
Okay, so
right?
I don't know because he will get an infection. If he gets an infection, he gets antibiotic.
Yes, you're right. For the person who has a normal lung, the infection clears and the lung is able to recover and it's no
Mm-hmm.
problem. But for a person whose lungs are already extensively damaged, these frequent and recurrent infections can create additional damage to the lung each time.
Okay.
So right now also, like he came to us with this chest infection, we gave him some very good antibiotics through his blood channels to help treat the infection.
Mm-hmm.
um, but he was still very short of breath, and we gave him some oxygen through a face mask. Unfortunately, he was not really responsive to all of the measures that we've been giving him.
What do you say when you say oxygen face mask? They put all the time, isn't it?
Yes, you're right. They've put it all the time, but this time we saw that the infection was really harmful to him. His oxygen levels in the lungs were really low,
Mm-hmm.
and when we gave him the extra oxygen, we tried to give him high oxygen in really high amounts
Mm-hmm.
to help him oxygenate the blood. But unfortunately, he could not tolerate that, and his oxygen levels are
What
continuously
is it? Is it is like
falling.
a different mask? What is it? Because you
Well,
said
it's
it
a
was a
mask.
horrible.
Oh, yes. Well, I appreciate that. Actually, this is a special type of device that helps to give oxygen at high pressures. When we gave him oxygen through a normal mask, he did not respond to that. His levels of oxygen did not improve. So the next step that we do is give them at higher pressures to properly ventilate the lungs. But unfortunately, he could not tolerate that. It can be very some patients feel that they cannot tolerate it because it's at high pressure,
Mm-hmm.
and they find it very uncomfortable.
Okay.
But unfortunately, this is the next step that we do. And in your father's case, he was of the view that he cannot tolerate it, and he feels that he cannot take that kind of
Okay.
treatment.
Mm-hmm.
So, well, his case was reviewed, and well, we discussed with him that if he feels he is not able to tolerate this treatment, we can give him the regular treatment, which is we can give him the kind of treatment uh, which is called as a palliative care.
Hmm. So what is it?
Well, in this case, when we find that generally when people have such an advanced disease that they are not able, which is not responsive to the treatments, and it is a kind of disease that will not reverse, and it is so advanced that it has caused some a very extensive damage, then we give this treatment called as palliative care, which is a type of a supportive care,
Okay.
um, by which I mean that we are just going to keep him comfortable in terms of pain relief, and
He
we'll
never
continue to
complained of
give
any
him.
pain. He never complained of any pain.
Well, right now he's pain free, but like I told you that his condition is expected to gradually deteriorate, considering that he's not responding to the treatment and he's not tolerating it. So I'm so sorry to say that there are high chances he's going to get even worse, and there are chances that he may stop breathing completely, and his heart may stop. I'm sorry for this
What? What did you say?
bad
Repeat that
news.
again.
There are very high chances that he may deteriorate further to the extent
Okay.
that his breathing and heart may stop eventually. I'm sorry, Miss Monica, for this terrible news.
So, I don't know. What are you trying to tell? Is he dying?
I'm sorry, Miss Monica, but yes, looking at the situation that he's not responding to the treatment and he's worsening, uh, it is highly likely that he is dying.
So, how long are we talking about?
Well, it's very hard to predict, but generally in this situation, we're talking about hours or few days.
Okay, then I want to take him home.
Miss
That's
Monica,
what he told me. See, he called me and said, "I'm not well. No, treatment is not working. So I want to come home." And he said none of the doctors talked about that. So that's why I came here to tell you, yes, I want to take him home. Yeah.
Okay. Well, Miss Monica, I'm coming to that. So we discussed all of this situation that we'll be giving him the supportive treatment, and in case he further deteriorates and his heart stops, we won't be giving him aggressive chest compressions, which is called
2 minutes
DNA
more.
CPR.
2 minutes more.
So yes, okay. So we will not be giving him aggressive compressions that will only increase his suffering. So he has agreed to this, and we can go to him right now. I can accompany you, and if he wishes to go home, we we can respect his wishes, and we can allow him to go home.
Right. So when he goes home, if he becomes short of breath, what do we do? Ring an ambulance and come to hospital again?
Well, that is something that we'll discuss in detail with your father. I'm going to, in your presence, we can talk to him that there's a high possibility he can deteriorate further to the extent that he will become even more short of breath and
So
his
what to
heart
do
may
with the
stop.
short
So
of breath? If he's short of breath,
if
what to
he,
do?
yeah, if he wants to stay in the hospital in such a situation, if you then it would be better if he didn't go home at the moment and stayed rather than coming back. But if he persists to go home and
Sorry,
spend
I
the
didn't
rest of
get
his
that
time
point.
there, then
What did you say? I didn't get that point. It's confusing. What did you say? Repeat that
um,
again.
we will discuss with him in detail again. If he wishes to come to the hospital in case he deteriorates further, it would be better if he stayed here rather than going home. Otherwise, if he
Okay.
wants to stay at home during this whole situation, then we can respect his wishes. We'll have to talk to him in further detail to understand what he wants.
But my question is, how do you manage his breathing? That you have not answered. Sorry.
Well, to manage his breathing right now, we're giving him oxygen via a simple face mask
But that is not
rather than
enough,
this
isn't it?
high
See,
pressure.
get my point. I'm always want to be straight. At the moment with oxygen, everything is okay, but you don't think he is responding. You said he is going down and he is likely to go down more. So when the breathing becomes worse, what to do?
Well, Miss Monica, you're right that it will get worse. What we can
So
do
what
is
to
we
do?
can increase the amount of oxygen we are giving by with the help of this mask. We can increase the levels of this oxygen, but
Okay.
there is a high chance that he will not respond to that even. So we can give him, um, like I said, we can make him more comfortable. If he complains of such thing, we can give him some painkillers. We can make him comfortable, but other than that, we won't be
What do
going
you
for
give
any
for breathing?
aggressive.
Because pain wise, there's no pain. What do you give for breathing?
For breathing, we can change the type of mask that we've used. We can try
Okay,
that,
time is
but
up.
there's okay.
Right, examine a time. Right, how was the conversation?
I think I tried my best to convey to her about whatever plan we have decided, and she got that point.
Okay.
But regarding the further worsening of shortness of breath, what we can do, I was not able to convey because I tried to tell her that he will worsen and his shortness of breath will worsen, and well, there's nothing more that can be done.
So, do you
That's
allow people to die with breathing difficulty?
with the breathing difficulty. If it is a reversible condition, then we can put them on the ventilator if they're not
Okay.
responding to non-invasive ventilation. But in his case, since palliative care and DNA CPR has been decided, so we will not be putting him on the ventilator. We can just give him oxygen with a simple face mask or via nasal cannula, and that's
So, do you
all that
think
can.
if the COPD gets worse, that will get better with the oxygen and face mask at home?
No, that will just be as a supportive measure so that he's not very uncomfortable in his last moments, but it will not correct anything now.
So, how can the oxygen alone make him comfortable, do you think, if he's having breathing problems?
Uh, I don't know what else we can do besides this.
Right. Okay. Um, do you think you have discussed about DNA CPR enough?
No, I just told her we won't be giving him aggressive chest compressions, which will worsen his suffering. And this is called as DNA CPR. And I told her that we discussed this with your father, and he's agreed. That's all I was able to tell because of the time shortage. I couldn't put more emphasis on that.
Why do you
And
think
she
there
didn't
was a
ask me
time
more
shortage?
questions.
Why do you think there was a time shortage?
Uh, she was not really clear about what COPD is. I had to explain that in more detail what it is. She was
Did
thinking
she
that it's
ask you
very.
about COPD?
She did not ask me about it, but her concept was that it is a long-term condition like diabetes, and it's possible to live with it with proper treatment. So I had to clarify that it at the moment it's extensive damage that he has suffered. So I had to explain to her from the basic thing so that I could tell her about the palliative care and DNA CPR, why
Mhm.
we have decided on that.
Is it still smoking significant here?
Yes, it is very significant because it is a major risk factor that causes the worsening COPD.
What do you do if he still smokes?
He's still smoking, and right now he is at his terminal stage. Then I don't think I will put much more emphasis on that because that's not significant at the time being.
So, what is the main significance of asking smoking history if you are not going to do anything?
I just wanted to tell her that this was the major risk factor that has caused this him to
Is that
have
relevant
this.
in this situation?
Um, well, just to clarify her about the disease, I told her, but I guess uh, maybe I could have omitted. But I wanted to tell her about the disease a bit more before I told her why we are not treating him further.
Okay. So she asked about taking him home, and you rightly said we need to go and ask him. So, what are the ethical considerations we are doing here?
if he has full mental capacity, which I think he has right now, because we discussed about the whole palliative care and DNA CPR with him. So considering that he has capacity, and so he has autonomy, if he wants to go home, keeping in view all of the pros and cons of it, then it is his. I will respect his wishes, and he can go home. Beneficence is doing good to the patient. So we are not going for any aggressive measures like intubation or aggressive CPR. So that is in his best interest. Non-maleficence is also doing no harm by doing CPR and all that further aggressive therapy. And justice is treating him rightly, according to, regardless of his age, gender, and ethnicity, religion, etc.
Okay. Did you manage to tell about that he's not suitable for ventilator and things?
I wanted to touch on that, but since the surrogate did not ask and I had more things to discuss, so I did not discuss that. Although I just mentioned it in a line that we won't be taking any further aggressive uh, treatments. But I didn't exactly mention the ventilator. He didn't ask me, so
What do you
I
think
didn't.
her main concerns are?
Her main concern was that firstly she was saying that it's a chronic condition, so probably he can live long, even if it's a routine for him to have frequent chest infections, so probably he'll be treated this time as well and he can go home. So I had to clarify that this was a worse
Time is
situation.
up.
I had to tell, yeah.
Right now, out of patient, everything done now. Okay. How was it?
It was okay, but the last point I did not know how to address, about what will we do if he still is short of breath.
Okay. Anything else you want to ask me before I tell you the feedback?
Uh, no, I think I'll take the feedback from you.
Okay. See, first of all, about the COPD, it's a very, very long explanation. So you have to cut down into small sentences. It's a very long explanation. It's very difficult to follow as a surrogate. If I'm a medico, I'm okay. I can follow up, but it's a very long explanation. I personally don't think that much of explanation is needed here. You can ask the surrogate, so diabetes and COPD, do you know what's the difference between these two? Are you thinking are they same? Something like that. Is let them talk, and then you can add up rather than telling from the beginning lungs, windpipes, and damage and things. That's what I feel. The second thing, smoking, I don't think is relevant here at all, actually. So I would say that's why at least a minute we are talking about smoking. I don't think that's relevant here. And lots of extensive damage. The wording is too strong and too early. So if you find anything else, that would be good. And you said in the normal person it won't be like that, but with COPD, with the bad lungs or worse lungs, he can. But again, rather than telling normal person, you can tell people with normal lungs, or because you're comparing the lungs. See, normal person, the opposite is abnormal person. Nobody likes to label as abnormal person. Normal person means we can tell healthy people or people with the normal lungs or people with no problems in the lungs rather than labeling normal. It's just like a labeling. Everyone is normal, you are not normal, something like that. So that word needs to be avoided. And there is a big catch in terms of non-invasive ventilation here, but you totally forgot about it. You just mentioned about the face mask, and I have to give clues as a special mask and things. You, after 1 minute, you came to discuss about non-invasive ventilation. So you need to be very careful about reading the scenario. And you said ventilate the lungs once. Again, there is a different ventilation is not the jargon, but it's very difficult to understand. And another time you said when the case was reviewed, never use case in UK. It's not a case. Case means it's the object. So they always consider the situation was considered and your dad's condition was considered, something like that. And he said high chances of deterioration. See, he will deteriorate. There's no high chance or low chance. He will deteriorate. And then you said, in terms of prognosis, how is today's? That is right. But I think it was immediate answer. Maybe you could put some command and do sentence and then come back. Just a 10-20 seconds over there gap. And the DNA CPR was a very long sentence again. I think you have to cut down your sentences. It's very long and very difficult to follow. And I said, and that's why I said, like, it's a very confusing statement. You said, like, if he goes home and if he want to come back to stay in the hospital rather than being at home, it is better. That's a very confusing statement. So you need to break down your sentences. And again, as you rightly said, you're not aware of the other treatment. So you said increased level of oxygen. You can't do, say you can do only up to 15 liters with non-rebreathing mask. You can't do more than that. And what is the next step? Unless you know, you won't know the answer. And then again, shortness of breath and type of mask, it's completely different. It's not like a different mask and different things. See, palliation, and again with COPD, we won't increase the oxygen. Even when the patient is dying, we won't increase. And the thing about oxygen and breathing and oxygen in palliative care is mainly related to the comfort. If that is helping people, you are going to give. You are not going to do the sacs and monitor it. If somebody desaturates to 70, 60, you don't rush and give 15 liters of oxygen over there. That is what the feedback I would like to tell you.
Okay, and sir, like in this case, what did palliative care constitute? Because I didn't know we're already giving antibiotics. What else can I tell?
Oh no, for the breathing, so you each and every time, the key point I wanted to stress in the whole scenario is each and every time we say, I'll refer you to palliative care, will make you comfortable, will make you pain free, but we need to know inside out to say what is what. Because when you say pain, I said not in pain. So palliative care is not about pain. People can have pain, people can have sickness, people can have breathing difficulty, and then we give medications to calm them down and to make them comfortable. On what medication here? There is a role of opioids like morphine comes here. So the answer to the problem breathing is opioids or morphine. And palliative care here is looking after the whole person. So you make him comfortable depending upon what symptoms he has, and then look after his family, and then looking after his wish. Let's say if he wants to go home, and then sending him home with extra support. And I said, like, what happens when he after goes home in the palliative care? There is a team in the community, so the community team will come to your home and look after him. So this is the explanation of palliative care. Without telling that, if we say, I will make you comfortable, that is what it's happening, I don't think there is no meaning in it.
And so when she said that, can we come back to the hospital if he worsened at that home? So how to answer that?
See, you can tell coming back to hospital. First is, see, what she is asking is, she's asking, one is medically you have to answer. Two, from patient's point of view, you have to answer. Medically, see, there's nothing you are going to offer in terms of treatment. So there's no, see, nothing we can, what we can do at home, we can do. So he doesn't need to come to hospital to go for another treatment. If he comes to hospital, what do? You're going to nebulizers that we can give at home. You're not going to give me NIV, no ventilation, no DNA CPR. So we are not going to offer anything more as he is. So in that situation, from professional point of view, I don't think there is a big benefit for him to come to hospital. At the same time, we need to ask his wish. If he is okay to come to hospital, again, we'll make him comfortable with opioids and morphine. But I'm reassuring you, we can do the same thing at home. If he wants to stay at home, we can do the same thing with the palliative care in the community.
Okay, sir,
Sir,
like you said, we'll give her opioids and how to tell this to the surrogate? Like
We
we'll
can
give him
tell
this
people
medication.
know. People
They
know.
know
We
about
can give
opioids?
morphine. Yeah, when morphine, everyone knows.
sir, I have two questions, sir. You said, sir, can I ask?
Mm-hmm.
Yes, sir. You said morphine in this patient we can give
Yep.
for pain relief. Morphine suppresses respiratory center also. So if suppose patient gets hypercapnic, shall we reduce dose of morphine? What precautions we should take? How
Yeah,
the dose of
morphine,
morphine
there
should
is a
be?
dose dependency. Morphine definitely
Yeah.
reduces respiration, and that again, that's beneficial in terms of shortness of breath. If he's, let's say, tachycardia at 30, 35 per, per respiratory per minute, and then giving morphine will make him comfortable, and then it is going to definitely reduce. But again, we are not giving a big dose of morphine. We start from the smallest dose and titrate them depending upon his requirement.
Okay. And sir, long-term oxygen therapy can we give if this patient comes again with uh, symptoms of shortness of breath? Is
He
he
is
eligible
on
for
he is on
lot? Yeah.
LTOT already because he has got oxygen at
Okay.
home. But with the LTOT
Okay.
is deteriorating. That's where the point is.
Okay. Sir, actually, I missed the starting session. He has DNA CPR. He was declared or
Yeah,
what
he
was
was
the
DNA
case?
CPR. Yeah, we are. Medical team
Okay.
decided DNA CPR. He agreed, but he wanted to discuss with his daughter.
Yeah. Sir, can you please take 5-10 minutes lecture on the group? Can you share about DNA CPR rules and regulation, when to declare the patient and when to like that? These are
Okay, right.
legal issues. Yeah,
Yeah.
I'm little confused about this DNA CPR, when to allow a vent or not to, because regarding patient attorney, if we say patient is eligible for DNA CPR but the relative is not wishing to do, like that cases occur. In that case, what we should do
See,
if there are two?
in short, DNA CPR is a medical decision.
Hmm.
There's no role of autonomy here. Autonomy,
and
people
if
can only refuse treatment. People
and
can't
if yeah,
demand any treatment. People can't say, please do CPR. I want CPR to be done. I want
yeah,
chemotherapy. I want
this
radiotherapy. People
relative
can't say.
can't say this. Okay.
Can't say this.
Relative
Even the
don't
patient can't
doesn't
say
have a
this.
right to. Yeah.
Patient can't say this. No one can say this. No one can demand any medical treatment legally. People can refuse treatment. People can't demand treatment. And the medical
Okay.
team, if we think some treatment is not going to be helpful, we are not obliged to give that treatment. So DNA CPR, in short, is a medical decision. People can't demand, but you can't say categorically to them. Your role is to explain why it is not going to benefit him. That's the role.
And sir, in this case, why this patient was declared because he was not coping with non-invasive ventilation? That's why.
No, he is dying. So end stage COPD, we tried
Hmm.
antibiotics and IV and everything, nebulizers, tried non-invasive ventilation. He won't be a candidate for invasive ventilation. So what else he would do?
Okay, that's why. Because of his condition.
Mhm.
Otherwise, he doesn't have any other comorbid like malignancy or any.
No, even see any end
I.
stage disease is a DNA CPR. End stage heart failure, end stage liver failure,
Hmm.
end stage chronic kidney disease, end
Hmm.
stage, like for example here in the COPD, anything end stage. Yes, that means they might be dying. In this case, definitely dying. So DNA
Hmm.
CPR. Okay, we
Okay.
will get questions from someone else.
Yes, sir. About this is what we call terminal care for this
Yes,
patient, because
yes,
when we are getting this scenario that non-invasive ventilation has not helped, and
yeah,
this is a COPD case, and because of his before pre-morbid condition, or the history of having repeated infections and scarring of the lungs will not it has no effect on the treatment. Basically, the last part I was also having I was also confused about the further care of the patient, because nothing is giving any help. It mean this is the terminal care, and for the terminal care at such stage we can give the this treatment at home also. Palliative care, it is written that he has been decided for the palliative care.
hmm,
Palliative care, it starts when the patient is already having this oxygen therapy at home. Basically, this palliative stage, this is the I think this is the late stage of or the terminal care situation.
yeah. It
And
all
I want
depends
to
upon
go
when do
to
you refer, isn't it? See, this patient has not been referred before. The respiratory team was
okay,
doing it. Now only is a trigger, and because of repeated
yes,
chest infections, you think it may not help, and you conclude and you refer to them.
Okay, okay. But actually, for at this stage, the care we need this to know elaboration about the further what we can do, and it is very good case. And I wanted to know at this stage what we can do as a terminal care, or if we call it as a palliative care, how much
See,
we can do, and
palliative care is a big terminology. Inside the
yes, it
palliative
can be
care,
for yes,
there is end of life care. And end of life care
yes,
is the last 1 year of life. And within the
yes.
end of life care, there is a terminal care. Terminal care means last days of life.
Last days. Yes, this is the terminal care. I think
Yeah, we are talking
from
about
what I
dying
understand.
last days of life. In the last days
Okay.
of life, again, that's unfortunately candidate didn't go that end in terms of morphine and things. So usually what we
Yes.
say is we'll give oral morphine for to help with the breathing and make her comfortable, make him comfortable. But if the people can't take, let's say sleepy, drowsy, can't take orally, then you have to give them syringe pump with the injection morphine in it to make them calm. So you need to. That's a whole. I was expecting to go through all the discussions in the next talk, but unfortunately time was not there. Okay, somebody else
Okay.
raise their hand. We haven't got much time. Sorry.
For the son, he asked about to take the father home. Just I
Sorry. Tell
want
me
to know.
again.
I have. He asked to take his father to home.
Yeah.
I have the right to tell him you can take him home, or better to ask the palliative care treatment team. Is it stable to take him home or no?
No, it's nothing like a stable or not. Because even if he's not stable, if he wants to go home, we have to send him home. There's
Yes.
nothing
So in
stable here.
palliative,
He is going to deteriorate. We are not going to see. One thing is when people are in the end stage of life, whatever you do in the hospital, you can't prevent them dying, unfortunately. So he is going
yes.
to deteriorate. He is going to die.
If he wanted to take his father for
Sir, in
traveling
this case,
for a journey, he can take also.
Again, if he wants to take the risk, he can
If
go.
he,
He might. So we need to tell him. If he's like a completely moribund, he's not moribund. He's talking and he's told his wish and all. See, what you are talking about is, for example, unconscious patient taking last breath of
yeah.
life, and do you send them to ambulance? Then we should tell them, okay, he might die any minute. Unfortunately, even he can die in ambulance. But if they are still wanting to take him home, you can. Right, there's
sir, in
one
this
more.
case, do
Wait
we?
a minute. One more person is raising a hand.
Yeah,
Who's that?
yeah, Dr. Ramesh. One question. That is, here we should ask about the lasting power of attorney.
You can. Yep.
Okay.
See,
Sir,
at the
if
moment he
surrogate
is
has
compatible. He's having competence, but if not, you can ask. Yep.
Sir, what about the ventilator? If surrogate is not insisting on it, should I spend time on telling her about it?
I don't think so. See, when you talk the DNA CPR, you can cover, not like a separate topic.